This is my podcast for the basic board review prep. This podcast focuses on questions related to the adrenal gland. This is a list of questions that have appeared on recent ABA board exams. Those designated with an A appeared on an advanced exam. Those designated with a U appeared on exams before the board exam was divided into advanced and basic exams. Those designated with an M appeared on maintenance of certification exams. Questions appearing in red are those which will be discussed in this podcast. Here's the first question. Pause the playback to allow enough time to read the question and select your response. Addison disease is, by definition, primary adrenal insufficiency. In the United States, the most common cause of primary adrenal insufficiency is chronic steroid use. The prevalence is about 1 in 10,000, and it occurs about twice as often in females as in males. Notably, almost half of the patients with Addison disease present in an adrenal crisis. From an anesthetic perspective, the primary concerns relate to deficiencies of mineralocorticoids and glucocorticoids. This slide shows the mechanism of action of aldosterone. It combines with a mineralocorticoid receptor in the cytoplasm and then is transported to the nucleus, where it is responsible for creating proteins that increase sodium reabsorption. Absence of aldosterone results in hyponatremia. This table lists the frequency of abnormalities of different lab tests in patients with Addison disease. It's obvious that hyponatremia is by far the most common abnormality. This slide lists the signs and symptoms of Addison disease. Pause it if necessary to review them. These are the most commonly accepted criteria for the diagnosis of orthostatic hypotension. The change in blood pressure is recorded within 3 minutes of changing from supine to standing or being placed on a tilt table at 60 degrees. Although reflex tachycardia commonly occurs, it is not part of the consensus conference definition of orthostatic hypotension. These are the results of a survey sent to 150 physicians and medical students inquiring about what testing was important in 3 different clinical scenarios suggestive of hypovolemia. Note that measurement of heart rate and blood pressure in the erect patient was viewed as being important by fewer respondents than obtaining electrolytes and blood counts. Lest we be too critical, consider the last time you put a hypotensive patient in Trendelenburg position. This is the next question. Make sure you have sufficient time to read the STEM and the distractors and then to select your response. Note that this question is specifically related to critical illness-related corticosteroid insufficiency and not simple corticosteroid insufficiency or Addison disease. The next series of slides show how cortisol works. I'm not an artist, so please bear with me. The blood vessel, red, perfuses a cell, blue, which contains a nucleus, purple. Cortisol is released into the blood by the adrenal cortex. Under normal circumstances, approximately 90% of cortisol is bound to cortisol binding globulin, and another 5% is bound to albumin. That means only about 5% of cortisol is free. Accordingly, since the action of cortisol occurs as a result of the free hormone, a simple serum cortisol level, which does not take into account changes in cortisol binding globulin or albumin, may not reflect cortisol activity. In any event, the unbound cortisol diffuses into a cell where it binds to a glucocorticoid receptor. The cortisol-glucocorticoid receptor combination enters the nucleus of the cell where it interacts with DNA and increases production of RNA, ultimately resulting in an increased concentration of proteins that are responsible for the ultimate response of the cell. Testing for adrenal insufficiency is problematic. In addition to the fact that normal values for cortisol vary throughout the day, there is no consensus about what stimulation test is best. Another problem with a random serum cortisol is that the level should be increased in critically ill patients. It is, after all, known as the stress hormone, and critical illness is a stress, so the levels should be increased. The problem is there's no consensus about what constitutes a quote normal unquote cortisol level in a critically ill patient. This slide shows the levels of cortisol, ACTH, and target organ hormones during an acute illness. This algorithm shows different responses to an ACTH stimulation test in critically ill patients. First, it needs to be noted that the algorithm as initially published included a typographical error. The box which currently shows a cortisol level of less than 15 was published as a cortisol level of less than 34. That's obviously incorrect. It essentially duplicates the middle category. Second, there is no consensus on what constitutes critical illness-related corticosteroid insufficiency, a term which is currently preferred over relative adrenal insufficiency. These data are derived from a series of studies assessing mortality in critically ill patients. Essentially, the patients who do the worst had either a high baseline cortisol level and a poor response to ACTH, or had a low baseline cortisol level and a poor response to ACTH. One more admonition. These results are from patients receiving a high dose, 250 microgram, ACTH stimulation test. A low dose test, 1 microgram of ACTH, is also sometimes used. Interestingly, the low dose test results in more patients being diagnosed with adrenal insufficiency and to be more effective in predicting which patients will respond to steroid administration. Other than dexamethasone, glucocorticoids have mineralocorticoid effects. This occurs because glucocorticoids bind to mineralocorticoid receptors. Accordingly, it is generally not necessary to administer fludrocortisone in addition to a glucocorticoid unless the glucocorticoid is dexamethasone. A decrease in corticosteroid binding globulin occurs with critical illness, as demonstrated here. Note that the first day of the sampling is the first day of a critical illness. Since the study was conducted in patients who became sick, there were no baseline values for comparison. The results have ramifications for interpreting serum cortisol levels. Obviously, a low serum cortisol level may be associated with a normal level of free cortisol as a result of a decrease in corticosteroid binding globulin. One last thing, not specifically related to the question, but still relevant. Note that the rate of adrenal insufficiency is proportional to the number of organs involved in the critical illness. To review the question slide, although much has been written about ACTH stimulation testing, there is no agreement on what constitutes an abnormal result, or, for that matter, even the dose of ACTH that should be used. Because most glucocorticoids, other than dexamethasone, have significant mineralocorticoid effect, it is not usually necessary to administer fludrocortisone in addition to a glucocorticoid. The hallmark of critical illness-related corticosteroid insufficiency is a lack of responsiveness to both fluids and vasopressors. This is the correct answer. As noted in a previous slide, levels of corticosteroid binding globulin are decreased, not increased, during critical illness. This is the next question. This prospective cohort study on otherwise healthy patients evaluated the presence of relative adrenal insufficiency in 120 patients undergoing surgery requiring cardiopulmonary bypass. Relative adrenal insufficiency was diagnosed based on a response to a high-dose ACTH stimulation test. The results showed that use of Etomidate for induction was the only factor that correlated with relative adrenal insufficiency. If a single dose of Etomidate was used for induction, the odds ratio for developing relative adrenal insufficiency was 6.55 with a confidence interval of 2.5 to 17.4. The results of this meta-analysis show an association between mortality and the use of Etomidate for induction and intubation in ICU patients with sepsis. The relationship existed despite controlling for multiple variables. Although patients with Addison disease may be more sensitive to the effects of neuromuscular blocking drugs, none are considered contraindicated. Because of the potential for development of hypotension, if propofol is used for induction, the dose should be reduced, but it is not considered contraindicated. This is the last question. Make sure you have sufficient time to read the stem and the distractors and to select your response. The first thing is that it should be evident from the prior discussion that it is not feasible to test every patient who has received steroids to determine whether or not they have adrenal insufficiency. In addition to the fact that there is a general lack of consensus on what test results constitute adrenal insufficiency, there is even disagreement on what constitutes the most appropriate test. This table, from 50 years ago, summarizes the situation relatively well. This slide illustrates the fate of inhaled steroids and indicates the mechanism by which systemic effects may occur. Adrenal suppression has been reported to occur in patients using superpotent topical steroids. Generally speaking, the threshold is application of 2 grams per day for 2 weeks. Risk of suppression is increased in patients treating large areas of skin, applying an occlusive dressing after use, and in patients with liver failure or poor skin integrity. It should also be noted that young children are reported to be more susceptible than adults. Just as administering steroid prophylaxis based on steroid use has been evolving over time, so many people now suggest that the type of surgery not only dictates whether or not steroids should be administered, but how they should be dosed. This table presents the most recent recommendations for prophylactic steroid administration based on surgical procedure. This table presents the recommendations of endocrinologists. Note that the doses are given in milligrams of prednisone. An equivalent dose of another agent, for example 16 milligrams per day of methylprednisolone, would have a comparable effect. Although the conventional wisdom is to treat patients who have received steroids in the last 12 months, data reportedly do not support this as being necessary. That having been said, the consequences of being wrong are fairly severe, and while even a short dose of steroids is not innocuous, for many anesthesiologists the side effects justify prophylactic treatment. Even the most ardent advocates of steroid prophylaxis will generally concede that a patient who has not received steroids for the last 12 months is not at risk. This concludes this podcast. I hope that information will be useful to you in studying for the basic exam.